Lower limb amputation is a devastating complication of diabetes. Up till now, diabetes mellitus is the commonest cause for non-traumatic amputation.
85% of lower limb amputations in patients with diabetes is preceded by foot ulceration.
15% of all diabetic patients may develop diabetic foot ulceration during their lifetime. Of all late complications of diabetes, foot problems are the easiest to detect. Therefore, amputation can be easily prevented if our attention is shifted from the advanced lesion into the much earlier lesions.
The aim of this video is to guide medical staff to screen patients with diabetes for minor foot lesions and do minor procedures which can by the end decrease the rate of amputation.
This video will take you through foot examination, management of non-ulcerative pathology, management of foot ulcer. Foot examination. Examine the whole foot. Look at the plantar and dorsal surface, medial and lateral aspect. Heel. Examine tips and between toes. Detection of neuropathy. Diagnosis of neuropathy start with careful inspection and palpation. Neuropathic feet are warm with bounding pulse, prominent veins, dry skin and fissures caused by decreased sweating, wasting of the small muscles resulting in claw toes, high arch. Test for sensation of the feet. Touch, pain, temperature, ankle reflex. Using 10-gram monofilament, diagnose loss of protective sensation if the patient cannot feel the monofilament. Apply tuning fork 128 over bony prominence. Quantitative assessment of vibration sense could be done by neurosociometer if available. Loss of sensation to a 10-gram monofilament or loss of vibration perception are helpful in determining the future risk of the foot ulceration. Detection of peripheral arterial disease. Inspect the foot for color changes. Feel the foot for temperature difference. Palpate the dorsalis pedis artery just lateral to the tendon of flexor hallucis longus, and palpate the posterior tibial artery midway between medial malleolus and the Achilles tendon with foot passively dorsiflexed. The absence of both pedal pulses strongly suggests the presence of vascular disease. Systolic ankle pressure can be measured easily using a sphygmomanometer and handheld Doppler device. The sphygmomanometer cuff is wrapped over the lower part of the leg, just above the malleolus. Use the Doppler probe to identify the Doppler arterial signal. Inflate the cuff until the Doppler arterial signal becomes no longer heard. Slowly deflate the cuff and note the pressure reading when the Doppler signal returns. Ankle brachial index equal the highest pressure at the ankle divided by the higher systolic pressure of brachial artery. Defective feet perfusion diagnosed if the ankle brachial index less than 0.9. Deformity. Foot deformity cause an increase in foot pressure. Inspect the feet for high arched foot, prominent metatarsal head, clawing of the toes. Hallux valgus. Hallux rigidus. Hallux rigidus is decreased range of motion with loss of dorsiflexion of big toe. Neuro-osteoarthropathy, known as Charcot foot. It is a distraction of bones and joints associated with the neuropathy. It may lead to collapse of the medial longitudinal arch of the foot, resulting in rocker bottom deformity, under which ulcer is formed. This could be avoided by early diagnosis and proper management of acute stage. Acute Charcot should be suspected in any patient with neuropathy if they present with a hot, red, swollen, and sometimes painful foot. Non-ulcerative pathology. There is no trivial lesion of diabetic foot, as minor lesion can lead to ulcer. Bully. Maceration. Nail abnormalities. Deformed nail. Ingrown nail. Thick nail. Callus. Callus is a warning that dangerously high mechanical forces are acting on the foot. It occurs on sites of high pressure. Hemorrhage within callus is an important precursor of ulceration. Ulcers. Ulcers on the plantar surface are usually neuropathic, and ulcers on the margins of the foot are usually neuroischemic. However, ulcers can appear on other sites. Interdigital and dorsal ulcers can be caused by tight, ill-fitting shoes in both neuropathic and neuroischemic feet. Detection of infection. Infection in a diabetic foot is potentially limb-threatening and requires urgent diagnostic and therapeutic attentions. The regular signs of infection could be lacking in people with diabetes. Inspect and feel the skin for color changes, worms, swelling, discharge, bad smell and pain. Look for maceration due to fungal infection. Footwear. Foot examination is never completed without an inspection of the patient's footwear. Proper footwear should be properly fitted, wide toe box, rocker rigid outsole, soft insole, seamless construction, extra depth to accommodate custom-made insole. Before the patient leaves the clinic, he should be instructed about foot care. At the end of examination, the frequency of the follow-up visit depends upon risk categorization. No sensory neuropathy, once a year. Sensory neuropathy, every 6 months. Sensory neuropathy with signs of peripheral vascular disease and/or foot deformity, every 3 months. Previous ulcer and/or amputation, every month. Management of non-ulcerative lesions. Cutting and trimming of nails. Cut the nail straight across. If the patient has thick nail, refer him to specialized foot care clinic. Callus. Special attention should be paid to area of callus, as ulcer may be imminent if neglected or treated inappropriately. Stretch the tissue to maintain good skin tension and ensure even removal of callus. Remove layer by layer. Regular follow-up, emollient, and pressure assessment with custom-made insole can prevent ulcer occurrence. Bully. Drain tense bully by cutting across the roof of the bully. Evacuate the content and inspect the base. Management of ulcer. Apply gentle traction. Remove all calluses surrounding the ulcer with a sterile scalpel. Cut away all slough and non-viable tissue. Debride from middle outwards. This carries debris and bacteria away from ulcer bed. Probe the base. If the probe reaches bone, this is suggestive of osteomyelitis. Clean ulcer with a sterile normal saline. Take deep swab tissue sample and send for culture. Size should be measured by using strips of graph paper in a small regular ulcer. If the ulcer is irregular, use two transparent papers. Draw the ulcer outline. Discard the layer in contact with the ulcer. Write the name of the patient, direction, and date. Bleeding after debridement can be controlled by pressure, calcium alginate, and ask the patient to rest and elevate the foot. Apply sterile dressing held in place with light bandage, which should not be wrapped too tightly or encircle the toe. Review at regular intervals and repeat the procedure. Relief of mechanical pressure is mandatory. Different methods of offloading add a great help to the process of healing as total contact cast, removable cast walker, cast shoes, therapeutic footwear.
By the end, screening of diabetic foot, risk categorization, and simple intervention as shown in this video, we can all reduce the rate of amputation among diabetics in Egypt.
Through this scientific effort of my team, your active participation across the country, and the generous grant of the World Diabetes Foundation, the dream of prevention of amputation in our country can come to reality.